Hi, Akif. How are
Hi,
you
how
doing?
are you? Fine, thank you. How are
Excellent.
you?
I'm all right. Akif, you'll have to switch on your microphone, which is present at the
Yeah.
bottom of the screen, left-hand side.
Yeah, can you hear me? Can you hear me?
Yeah, I can hear you very well. I need to see you.
Yeah. When I push the start video, it says you can't start your video because the host has stopped it. You stopped it, it said.
1 minute, Akif. Just let me switch off. There's a YouTube thing in the background. Sorry, just 1 second.
Okay.
Okay, so I have stopped you. So hang on, chat. Let me just see, okay, where it is. Why don't you share your screen, Akif?
I can share my screen.
Give me 1 second.
Okay.
I'll just look at the settings and I'll just get your video on.
I'm sharing my screen right now.
Yeah, I can see your screen, but I can't see your video. I just want to see what is the problem there. Allow. Where is it?
Unable to start video.
Yeah, I can see your thing. Let me just look at your.
Okay, sure.
I'm trying to get your video on. I will.
Maybe it is better to reconnect. I don't know.
No, 1 second. Hang on. I can't see anywhere where I've stopped your video, actually, to be honest. I'm just trying to see. Because this one we're doing it as a webinar rather than a meeting.
Yeah.
So, who can share? All panelists. All panelists. I've given all permissions, Akif, as far as I can see. Try again. See if you can.
Okay. Unable to start video. Can you see this warning?
No, I can see your desktop. What I cannot see is your video.
Okay.
I'm wondering why.
Now, can you see the desktop right now?
I can see your desktop very well. It's not a problem.
Okay. So start video.
Video I cannot see.
Can you see this? Unable to start video. This
No,
one.
that is. Just click on the video again to show me what is coming up.
Okay. Video. Where is the video? Oh, yes. Unable to start video. Can you see this?
No, that is not showing up to me actually. Just 1 second. Let me see. View options. Okay. I have no idea why. Yesterday we did this and we had no problems actually. So let me just see. Screen share participants.
The host has stopped it. Very interesting. Invite.
Okay, let me see.
Maybe it is better to reconnect.
No, it's okay. Akif, hang on. I will just forbid record. Stop share. Let me make you host as well. Co-host with me.
Okay.
No, hang on. Then my video will go away. I don't know why your video is blocked here. Make host, change roles, forbid record, rename, put on hold, stop share. It doesn't allow me to switch on your video for some reason. Just looking at all the options here.
New share.
I did this before and I was allowed to do that. I'll tell you why this has happened, Akif. Is because I started the thing and I went live. And after you go live, you cannot change any settings.
Oh, okay.
I don't want to stop the live because people have already.
Do you want me to reconnect again?
No, I think it's okay. It's not you, it's me. I've already started because I should have done this in the practice mode where I could have given you the video permission. The thing is with the webinar, once you have gone live, I think you cannot change settings. That's what is the problem. I made, I went live before you logged in. I can see your face now. Very good. So
okay,
I can see you for sure. I can see yourself.
Okay. I choose virtual background here.
Yeah, that's okay.
It's okay.
Let me see.
It is okay right now?
Okay, what we'll do is we'll get you to start, Akif, with your slides, okay? And then,
Okay.
yeah, go ahead and start with your slides and we'll get you to talk and then we'll take question and answers at the end of that. Is that all right? Without your video?
Okay. Okay.
So share your screen.
Okay.
Share your slides. Yeah, I can see your slides. Okay. So
okay.
I'm gonna start recording. I'll introduce you and then we'll go live. Okay.
All right.
Right. I just want a. Okay, record on this computer. Hi, good evening, everybody. Welcome to another session of Thoracic Gurus. It's really been a great few weeks in terms of academic knowledge that we've all gained. And today it's really my honor and privilege to introduce to you Professor Akif Turna. Professor Akif Turna is one of the leading authorities in lung cancer management across the world. He is on the committee for International Society for Lung Cancer, and his understanding of the staging of lung cancer is second to none really around the world. And all of us take advice from Akif whenever we have difficult questions to answer. So Professor Turna, the floor is all yours. Let me introduce the audience to you. These are people who are logging in from across the world. We have exam-going students, we have young residents, we have surgeons, we have oncosurgeons and senior surgeons as well. So it's a wide variety of people who have logged in, and they are looking forward to hear your talk. And also it's live on YouTube, and we've got a big number of people logged in on YouTube as well. The floor is all yours, Professor Turna. Take it away.
Thank you very much. Thank you very much. Thank you also for the opportunity to talk about staging non-small cell lung cancer. Hi everyone. I hope you are staying well and healthy during these difficult times. I'd like to start with this slide, which shows the importance of lung cancer. Actually, when we look at the cancer statistics for United States of America, these are the numbers that are expected in 2019. Prostate tumor is the most frequent tumor among males, and breast tumor is the most frequently seen diagnosed tumor among women. But when we examine the death rates, the mortality, it is easy to see that lung tumor is the #1 tumor that causes most mortality in the world. Again, among women, lung tumor is #1 tumor that causes most deaths from cancers. So it is true for, of course, West countries like United States and the countries in Europe. And it is also true, as far as we know, it is true for the Asian countries. Only there are small number of countries in which the lung tumor is 7th or 8th, number 8 cause of death, which are the countries below the Saharan desert. So sub-Saharan, it is not true for sub-Saharan countries, but there are few. So let's start with the mammary carcinoma and the death rate and the mortality rate of mammary carcinoma. Approximately 60 out of 100 women who had mammary carcinoma can live beyond 10 years. It's about 60% for all stages. But there is a different story about lung cancer. As you see here, only 7% of patients can survive beyond 10 years. So there is a big difference between breast cancer and lung cancer. And it is suffice it to say that lung cancer, it is very easy to understand actually why lung cancer is the #1 mortality cause among women, even the fact that breast cancer is the most frequent one. But there is good news, actually, that the survival of lung cancer has been increased during last 3 decades. As you see here, 5-year survival rate used to be 12 during 1970s. It increased to 13 and during 1980s, and increased to almost 20 for almost all, of course, stages. This is good news, but as you see here, it is one of the worst cancers in terms of survival. It is even equal to liver and intrahepatic bile duct cancer. So, of course, today, this evening, we will be looking at TNM as staging parameters. But in fact, there are many factors that determine survival. There are tumoral factors, including TNM, histopathological factors, but also there are environmental factors that determine survival of the patient, and also patient factors. Patients' host factors are important, of course. Immunity is one of the most important parameter that determines the survival. But as surgeons, it is very, very difficult to analyze other factors like environmental factors and patient factors. And as surgeons, we are fixated to look at TNM factors as the most important factors, but these factors can define only 60% of 60% of the patients, and only the sensitivity is about 80% for TNM. But we have to use TNM because these factors can be defined clinically and radiologically. So what is TNM stage? What is stage? Actually, it is a function.
Akif,
yes.
I just, sorry to stop you. I just allowed you to share your video. So can you switch on your video, please? I just found where that link was.
Okay.
Sorry about that. Yeah, fantastic.
Can you see me?
All right. Yeah, we can see you now. Thank you very much, Akif. Sorry, please continue.
Okay. What is stage? Stage is a function of 3 parameters, actually, namely T and M. T stands for, of course, tumor. N is used for nodular metastasis. And M stands for distant metastasis or intrathoracic metastasis. So, should we use only one type of TNM? The answer is no. There are at least 3 types of TNM. Actually, there are 6 types of TNM, but only 3 of them are useful in terms of clinical factors and radiological definitions. Clinical staging is constructed by the radiological examinations and the clinical examinations. So when we talk about clinical staging, it means that we reconstruct the staging looking at the radiological findings and the clinical findings, such as bronchological findings and other findings that can be obtained from biochemistry or other assessments. So surgical pathological staging is more accurate staging compared to clinical staging because it stands for the staging after resectional surgery. So after pathological examination, the TNM staging becomes more and more accurate, and overstatement or understatement becomes less and less frequent. Restaging after initial treatment the acronym for that is YTNM. For example, if you send the patient to neoadjuvant therapy, and if you restage the patient after neoadjuvant therapy, neoadjuvant chemotherapy or chemoradiotherapy, we should name it as YTNM, as restage TNM. So what is the importance of T factor? T factor is very important, actually. When we look at these survival curves, when we look at the patients without nodal and nodal metastasis and distant metastasis, the 5-year survival of the patients with T1A is 92%. It means that almost all patients can be cured when the tumor is T1A. But for T2B, it's very different. Only half of the patients can survive beyond 5 years. So T factor is very decisive factor. Of course, N and M factors are important, but T factor is very decisive, and it can be found, or it can be obtained by radiological examinations. So let's look at T descriptors. According to 8th TNM staging, small tumors are named as T1A, small tumors up to 1 centimeter. Between 1 and 2 centimeter, it is called T1B. Between 2 and 3 centimeter, it should be staged as T1C, as a T staging. And it continues. Every centimeter counts in terms of T factor. 3 to 4 centimeter, it is 2A. 2TB, T2B means the tumor is between 4 and 5 centimeter. If the tumor is larger than 5 centimeter but smaller than 7 centimeter, the T factor is 3. And if the tumor is larger than 7 centimeter, it should be staged as T4. So this is survival rates according to T factor at Cerrahpaşa. As you see, these are very these curves are similar to those obtained by International Association of Lung Cancer Society. So how can we evaluate the T factor? Of course, chest X-ray is the simplest method and should be the first method to evaluate the T factor. But the sensitivity and specificity are very low when we use only chest X-ray. So we use CT scan and PET-CT for the evaluation of T factor before operation or before any definitive treatment. Magnetic resonance imaging is used, but in very small number of patients, very select patients. It is useful for spherosulcus tumors, vertebral diaphragmatic invasion. It shouldn't be used. The frequent it is used sometimes for the invasion to mediastinal structures, but usually it exaggerates the mediastinal invasion. So it shouldn't be used usually for mediastinal invasion. So what can we see when we look at chest X-ray, CT, and PET-CT? Of course, as I told you, chest X-ray is informative, but sensitivity is and the specificity are very low, very suboptimal. But as you see here, the borders and the density can be predicted when we look at chest X-ray. Chest PET-CT shows the border very clearly, and also the metabolic activity, which is a suggestive parameter for a presence of tumor. So just look at T factors one by one, by examples. The left of the slide shows the tumor, T1A tumor, which is smaller than 1 centimeter, as you see here. There is a right lower lobe tumor, which is T1B, between 1 centimeter and 2 centimeter in diameter. T1C means the tumor is greater than 2 centimeter, but smaller than 3 centimeter. So this shows a tumor, T1C tumor, which is 2.5 centimeter in diameter. And you see the positivity, FDG positivity, and it is about 5. SUV value is 5, which means it is a very highly suggestive of tumor. So the picture is not too beautiful as the T1 tumors. Let's look at the T2 tumor. T2A tumor means the tumor is between 3 and 4 centimeter, as you see here. If the tumor is invading visceral pleura, it is called T2A again. If the tumor is larger than 4 centimeter but smaller or than 5 centimeter or equal to 5 centimeter, it should be staged as T2B. According to 7th staging system, if the tumor caused total atelectasis, it was staged as T3. But according to this new staging system, which is the 8th staging system, if the tumor is associated with atelectasis or pneumonitis, it should be staged as T2A. If the tumor is smaller than 4 centimeter, it should be staged as T2A. If the lesion is larger than 4 centimeter but smaller than 5 centimeter, it should be staged as T2B. This shows that T2B tumor, as you see here. It's about 4.5 centimeter in diameter. It is a right upper lobe tumor. This is again a T2B tumor. It is 5 centimeter in diameter. As you see here, the border is irregular. And again, it's a hilar tumor, which is T2B. According to 7th staging system, if the tumor invades the main bronchus, it used to be called as or named as T3. But according to new staging system, it should be T2A or T2B, depending on the size. So this is a specimen showing a T2B tumor. So this shows a tumor causing left upper lobe atelectasis. In this sections, it is not possible to see the tumor because it obstructs the left upper lobe bronchus totally. But we see here is the totally atelectatic left upper lobe and air bronchogram. So this slide shows some examples of T3 tumor. If the tumor is larger than 5 centimeter but smaller than 7 centimeter, it should be named as or staged as T3. If the tumor is invading chest wall, it is T3 tumor. If the tumor is invading parietal pleura, it should be staged as T3. And if there are separate tumor nodules in the lobe in which the primary tumor is, it should be again staged as T3. If the tumor is invading or abutting the phrenic nerve or parietal pericardium, again it is T3 tumor. There is a small difference between actually T3 tumor and T2 tumor. If the tumor invades, as you see here, the parietal pleura, it transgressed the parietal pleura with visceral pleura. It should be staged as T3. PL3 and PL2 tumors should be staged as T3. This tumor is invading the elastic layer of the visceral pleura, and this tumor, as you see here, invading the visceral pleura as well as the parietal pleura. But PL1 is not a T3 tumor. So this slide shows a tumor, one of our patients who had a left-sided tumor abutting and invading the chest wall, as you see here, just around vertebra. So again, this is a chest wall tumor, T3 tumor, invading more than 3 ribs. Again, this shows a T3 tumor. Actually, the sensitivity of radiological or CT is not so high. It's about 85% in order to show the T3 tumor. But chest wall pain is more sensitive than CT. And also, if you have a next generation CT machine that takes a 1 millimeter thickness chest CT, it's again more and more sensitive for T3 involvement. So what are the T4 tumors? If the tumor invades main structures such as trachea, carina, aorta, esophagus, or vertebra, this tumor should be staged as T4. This is actually some of the T4 tumors are operable, such as the tumor invading trachea, carina, and vertebra. Technically, of course, the tumor invading aorta can be resected with some aortic surgery, and also it is possible to resect esophagus with tumor and also with the lung, adjacent lung. But these operations are not recommended because of the survival rates. So this tumor is invading diaphragm. The diaphragmatic invasion became T4 for the 8 staging system. Carinal involvement is again T4. It should be named as T4. You see here, there is a tumor invading main bronchus and also the carina. It also actually invades left main bronchus. We perform sleeve carinal resection to this patient. Vena cava superior involvement is again another type of T4 tumor. And sometimes the tumor invades vena cava superior as well as mediastinum. As you see here, this is a T4 tumor. The question is, which T4 tumors are operable? Which tumors should we operate on? Of course, as thoracic surgeons with a large or giant ego, the answer would be to this question: if I can resect the tumor should be named as or deemed as resectable. But we have also always to look at the survival curves, and we have to ask ourselves if the resection is beneficial for the patient. We have to ask this question because there are more than two options for the treatment of the lung cancer, which are radiotherapy, chemotherapy. And when we consider the last 2 decades, we have to consider
targeted therapies and immunotherapies. So if we cannot obtain more than 30% of 5-year survival, I think we shouldn't operate the patient, because other modalities can provide approximately 25 or 30% of 5-year survival. But when we look at this nice survival curves from the study which was published from the thoracic surgeons in Paris, Dartovel's team, the survival, 5-year survival of the patients with superior sulcus tumors, choroidal invasion, superior vena cava invasion, or mediastinal invasion are about 35%, even for some patients 60%. So it is okay to operate the patients with T4 tumors, but these patients should have N0, means no nodal metastasis and no distant metastasis. Let's look at the N factor, which is very important parameter or component of TNM staging. So NX means lymph nodes cannot be assessed. N0 defines the situation in which there is no lymph nodes involved. N1 means there is a metastasis to ipsilateral or peribronchial or ipsilateral hilar lymph nodes. N2 means that there is metastasis to ipsilateral mediastinal or subcarinal lymph nodes. N3 means that there is a metastasis of ipsilateral supraclavicular lymph nodes or ipsilateral scalene lymph nodes or contralateral lymph nodes, hilar or mediastinal lymph nodes. N factor is actually more important than the T factor in terms of survival prediction, because as you see here, N0 patients, of course, these are all T factors here, T1 to T4. All N0 patients, 5-year survival is about 37%, while N1 patients can, only quarter of N1 patients can live beyond 5 years, and it is about 7% for N2 and N3 patients. It means that these are the patients that we should operate on. At N2 and N3 patients that are found to have nodal invasion before the operations should be referred to oncological therapy. Of course, there is neoadjuvant therapy, and some of the patients are candidates for neoadjuvant therapy and multimodal therapy, including surgery. What are the mediastinal hilar intrapulmonary lymph nodes? From 1 to 9, these are mediastinal lymph nodes. Basically, fundamentally, this is the medial mediastinum, as you see here, middle mediastinum. These are the supraclavicular, the highest mediastinal lymph nodes. They are usually not dissected. Upper paratracheal lymph nodes, lower paratracheal lymph nodes, 4. Subcarinal lymph nodes, 5 and 6, around and beyond the aorta. Paraesophageal lymph nodes, number 8, and inferior ligament lymph nodes, number 9. And from number 10 to number 14, these are named as N1 lymph nodes, hilar lymph nodes and intrapulmonary lymph nodes. 11 is interlobal, 12 is lobar, 13 is segmental, 14 is subsegmental lymph nodes. We can, as thoracic surgeons, we can sample or dissect 10, 11, or 12 nodes, but 13 and 14, the number 13 and number 14 usually are dissected by pathologists during the specimen evaluation. So this is more clearer, but less realistic picture. As you see, there are many sites for one station. For example, this shows the at least 5 locations for the lower mediastinal lymph nodes. If the lymph node, is proximal to main bronchi, as you see here, and if it is inferior to brachiocephalic vein, it should be named as right paratracheal lymph node. Below the aortic arcus, as you see here, it is named as lower left paratracheal lymph nodes. And above the brachiocephalic vein, these lymph nodes are named as upper paratracheal lymph nodes, right and left upper paratracheal lymph nodes. There are aorticopulmonary lymph nodes, which are numbered as number 5, and periaortic or anterior mediastinal lymph nodes, which are numbered as number 6. So these lymph nodes, number 5 and number 6 lymph nodes, are, as you know, specific for left-sided tumors. It is very, very rare, almost near to 0% to see aorticopulmonary or subaortic lymph node positivity seen in a patient with right-sided tumor. So if the lymph node is on the main bronchi, it is numbered as number 10. And after the first branching, as you see here, after this branching and this takeoff, it should be numbered as number 11, and so on. These are the examples of N0, N1 patients. This patient, this hypothetical patient, has a right lower lobe tumor, but there is no metastasis in the intrapulmonary lymph nodes or hilar lymph nodes. It should be staged as N0. This is N1 patient, as you see here. There is a tumor, left lower lobe tumor, and there is lymph node metastasis around hilum, as you see here, hilar lymph nodes. It doesn't matter if there is one or there are 2 or 3 lymph node metastases around the main bronchus or lower bronchus. This slide shows 2 examples of N2 tumors. So this is a right upper lobe tumor with right lower paratracheal lymph nodes positivity. And again, there is a left lower lobe tumor with hilar positivity and also left lower paratracheal lymph node positivity, which means N2. So this slide shows N3 patients. As I told you before, if there is a contralateral hilar or interlobal lymph node positivity, the patient should be staged as N3, or supraclavicular lymph node positivity or scalene lymph node positivity should be named as N3. If there is a higher lymph node, positive hilar lymph node, such as suprajugular lymph node, it should be staged as M1 rather than N3. So PET-CT is very helpful actually. It shows tumor and nodal involvement, but there is a caveat, there is a problem with that. As you see here in this patient, there is a tumor and also there are N3 and N2 lymph nodes. But as you see here, there is a halo around the lesions and the lymph node. This is because of a phenomenon which was described by physicists. Actually, there is a phenomenon caused by annihilation. During PET-CT, we don't assess the positron emission. Actually, we use FDG, fluorodeoxyglucose, which is tagged with radioactive fluor atom, which emits positrons. But there are very few number of detectors that detect positrons. instead of detection of positrons, we detect gamma rays. But in order to emit gamma ray, positrons should be annihilated with electron. There is a problem with that because atoms are 99.999999% empty structures. Actually, we composed of empty atoms. For this reason, a positron should travel at least 6 to 8 millimeter to meet an electron to be annihilated. For this reason, around the tumor, there is a halo, positive a cloud which shows the positivity around tumor and around nodules. So we should ask, does it make any difference? It makes a difference because 1 centimeter sometimes is very important around this area. If the lymph node is N1 or N2, because 1 centimeter distant from this area, this lymph node should be named as or staged as N2, but hyaline lymph node is staged as positivity is staged as N1. So for this reason, if you see N1 lymph nodes on PET-CT, there is a high possibility, actually more than 60% of possibility for having N2 positivity. So this is a problem related to subatomic physics. So what is the post-predictive value of PET-CT? Unfortunately, it is like tossing a coin. It's about 60%. And negative predictive value is about 75%, depending on the pretest probability. If there are many lymph node positivity shown on PET-CT, positive predictive value is higher, 90%. But if the tumor is smaller, the positive predictive value and negative predictive value decreases at a great extent. For example, this patient was one of ours. She was 41-year-old female. PET-CT shows hyaline lymph node metastasis, as you see here, but it turned out to be positive mediastinal lymph nodes, multiple positive mediastinal lymph nodes. This patient was a 71-year-old female. PET-CT shows that there are multiple N2 disease, but after mediastinoscopy, we showed that there was no lymph node positivity in this patient. So in T1 tumors, we can trust the negativity of PET-CT. We shouldn't trust the PET positivity unless the tumor invades mediastinum and unless the lymph nodes are bulky and positive. And if the tumor is T4 tumor, the accuracy is about 70%. And in all tumors, the accuracy is about 76 to 85%. So in which tumors we should trust, we should depend on PET-CT. Only we should trust T1 tumor, we should trust PET-CT when there is a peripheral small T1 tumor without mediastinal FDG avidity. So this shows ESTS. This shows the ESTS guidelines, which summarizes what I have told about the staging. As you see here, if there is a small peripheral tumor without any lymph node positivity on PET-CT, no preoperative mediastinal staging is necessary. If there is clinical N1 or if the tumor is larger than 3 centimeter, EBOS, EOS, if available, should be performed first, or video mediastinoscopy should be performed. And if there is lymph node, the lymph nodes are negative, mediastinal lymph nodes are negative, surgery can be performed. If there is a mediastinal lymph node positivity on PET-CT, should we send the patient to oncological treatment? The answer is no. We should require tissue conformation. If we have EBUS or EUS, we should perform it. EUS is very rarely performed. It is performed for number 9 lymph nodes usually, or number 8 lymph nodes can be reachable by EUS. If the mediastinal lymph node is positive, multimodality treatment is recommended. If there is a negative lymph node, even the fact that the PET-CT is positive, should we go on with the surgery? No, we should do video mediastinoscopy. If the mediastinal lymph nodes are negative, we should go on to surgery. So let's look at the mediastinal staging modalities one by one. EBUS TBNA actually fundamentally is a kind of high technology fiber optic bronchoscopy with a, as you see here, with a channel which is designed for a needle, and there is a ultrasonography probe here in order to see the lymph node and in order to discriminate the lymph nodes from the pulmonary artery or pulmonary vein or aorta. And bronchoscopists can describe the lymph nodes very clearly with the aid of the ultrasonography. And it is an, of course, a biopsy method, not a dissection method. And these lymph nodes can be biopsied with this needle. But mediastinoscopy, as it was shown in the ESTS guideline, is the gold standard. The mediastinoscopy started with a small incision, suprajugular incision, 3 centimeters suprajugular incision. After the dissection of the paratracheal fascia, mediastinoscopy is placed just below the paratracheal fascia. If you can dissect this paratracheal fascia, it becomes a very safe and the straightforward operation. And of course, during the last 20 years, we use video mediastinoscopies, and we usually, as a preference, we do video mediastinoscopy and/or video-assisted mediastinoscopic lymphadenectomy, which means dissection of whole mediastinal lymph nodes bilaterally with the aid of video mediastinoscopy. If in theory and in practical, in practice, if we dissect whole lymph nodes, it is possible to reach almost 100% of accuracy. Of course, it is a theoretical possibility. Usually, VAMLA can help to reach about 96% of accuracy. So, of course, whole lymph nodes can be dissected, as you see here. Number 2R, 4R, 10. It is possible to reach number 10. Even you can reach number 8, paraesophageal lymph nodes, and it is possible to clear whole subcarinal area. And of course, 4L and 2L left paratracheal lymph nodes can be dissected completely. So this video shows a short clip of VAMLA. This is paratracheal area and trachea. If you didn't open it, you have to open before you place the video mediastinoscope. As you see here, it is a straightforward procedure to take whole mediastinal lymph nodes. Actually, it becomes easier to dissect the lymph nodes during the thoracotomy or VATS resection if you do this, because bilateral mediastinal lymph node dissection is possible with VAMLA. So what is the mortality or morbidity of this procedure? As a short answer, very low. Morbidity is about 2%, owing to usually temporary dysphonia. Approximately 12 years ago, we lost one patient because of this operation, and accuracy is about 95%. Of course, this includes video mediastinoscopy and video-assisted mediastinoscopic lymphadenectomy. And there is one more mediastinal staging procedure, which is called anterior mediastinotomy, or it is called Chamberlain procedure. It should be performed for the left mediastinal lymph nodes, namely number 5 or number 6 lymph nodes. So it starts with a small incision again, just onto the second rib, as you see here. It is your preference to resect the second rib, or you can leave the second rib and you can go down to the second rib, taking only the parietal pleura. But one should be very careful in order not to open the parietal pleura, as you see here. Mediastinal pleura should be open, and these are the lymph nodes from subaortic area, number 5 area, and these are the anterior mediastinal lymph nodes, which are number 6 lymph nodes. Here you can see these lymph nodes very clearly. There are many locations for these lymph nodes. It means that if you are obsessed to dissect these lymph nodes like us, you should look at these areas, all these areas. Extended mediastinoscopy can be performed. The advantage of extended mediastinoscopy is that you can use the same incision with the mediastinoscopy incision. And after the performing mediastinoscopy and sending the lymph nodes to the frozen section analysis, if the lymph nodes are negative, you can go on to the taking biopsy from number 5 or number 6 area. Of course, it should be performed in the left-sided tumors with the FDG positivity on number 5 and or number 6 areas. So it shouldn't be performed in the patients with calcified aorta. Video thoracoscopy is the last method to evaluate the lymph nodes before the operation. This video shows dissection and biopsy technique that can be used in the patients with right-sided tumor. If you didn't or you don't want to perform mediastinoscopy, it's a good method to take biopsy before the operation. This area is upper paratracheal area, number 4 and number 2 lymph nodes. This area just above the brachiocephalic vein here, it's number 2, upper right paratracheal. Lastly, but very importantly, M factor is one of the components of the TNM staging system. M0 defines a tumor without metastasis. M1A means there are pleural or pericardial or contralateral lung metastasis. M1B should be used for single extrathoracic metastasis. And if there is multiple extrathoracic metastasis, it should be staged as M1C. Either multiple metastasis to same organ or solitary metastasis to multiple organ means M1C. So this is my last slide. TNM, when you when you define T and an M factor, TNM staging should be constructed with using T and M factors, as you see here, T1A, T1B, T1C. These T1 parameters without no nodal involvement means that these are the stage 1A tumors. Stage 2 tumors are the tumors with M1 involvement. N2 involvement means the tumor, if the tumor is T1A, T1B, T1C, T2A, T2B, these tumors are T3A. If there is an ipsilateral mediastinal involvement in a patient with T3 tumor or T4 tumor, the staging should be T3B. And these tumors, 3B, 3C, 4A, 4B tumors are categorically inoperable tumors. But of course, there are some treatment modalities, multimodal modalities for some selected patients. Thank you very much for attention. These are the 3B, these are the survival rates of the tumors. This is why I told you that 3B, 3C tumors and 4A tumors are not candidates for operations. Thanks a lot.
Thank you very much, Akif. Professor Turna, this was just an amazing talk. This is a very difficult topic, particularly with the things changing every so often from 7 to 8. So it is difficult for the youngsters to keep up with what is the changes. And thank you very much for eliciting everything very clearly and explaining to the youngsters how to go down the TNM stages. I'm going to start with question answers. Are you okay with that, Akif? What we'll do is we'll stop sharing your screen and we'll bring you your video onto the forefront. So just stop sharing your screen. Yeah, excellent. So let me just bring you up on the forefront and we'll ask you some questions. You're looking different today, Akif.
Sure.
Haircut. Okay.
I think I should switch on the light.
Switch on the light. We like to see your face. Yes.
It's better.
Excellent. Okay. Thanks, Akif. I'm going to start with a few questions, if that's okay with you. Are you okay for
Yes,
time,
sure.
Akif? All right.
Yes, sure,
So
sure.
My first question is, could you once again clarify what are the changes to the current TNM as opposed to the previous TNM? Okay. So which were the specific points that changed from the 7 to 8?
Okay, there are a number of points actually. First of all, let's start with T1. According to 7 TNM staging, there was T1A and T1B. But today we have T1A, which means the tumor smaller than 1 centimeter, T2B, T1B, the tumor between 1 and 2 centimeter, and T1C between 2 and 3 centimeters. So before, according to 7 TNM staging, the size didn't matter in terms of a T3 tumor and T4 tumor. Actually, T4 tumor today is a tumor which is greater than 7 centimeters. There was no definition before that, and also the definition for T3 was 5 centimeters today. Between 5 and 7 centimeters, the tumor should be staged as T3. But in terms of elastic lamina or parietal pleural invasion, it is same today. According to 7th staging, if the tumor is on the near the carina, which is in 2 centimeter distance from carina, it used to be called as T3. But today, the tumor should be staged as T2 if it's on the main bronchus. And also there are some T factors that are removed from the staging system. The first one is T3. The second one is mediastinal invasion. If the tumor invades only mediastinal pleura, it doesn't mean any different T factor. But if it invades a major structure, such as vena cava superior, as I showed you, or main pericardial pulmonary artery, or aorta, or vertebral body, it should be named staged as T4. And also, according to 7th staging system, the tumor, if the tumor invades diaphragm, it used to be staged as T3, but today it should be staged as T4 rather than T3. And also, pericardial effusion was staged as T4 according to 7th staging system, but today it should be staged as M1A rather than T4 because these patients have worse survival, which are very similar survival to the patients with metastasis. And also, in terms of M1 stagings, according to 7th staging system, there was no 3 staging M1 staging, M1A, M1B, M1C. Today, if there is one extrathoracic metastasis, we should stage as M1B. If there is more than one extrathoracic metastasis, it should be staged as M1C. These are the main differences between 7th and 8th staging system.
So let me come back to you and ask you a very basic question.
Yes.
Why were these changes made? I mean, it was already confusing, and now we've got more stages. So why were these changes made between 7th and 8th? What is the clinical impact of this?
This is very important. So there is very weak point about lung cancer. Actually, when we look at other staging systems, naming the staging, every stage could predict survival of the patients at an accuracy of 95 or 90%. So in a statistical figure, the R factor is about 0.9 or 0.7. But for the 7th staging system, during the 7th staging system, it used to be about 0.7. It means that only 70% of patients, the survival could be predicted in only 70% of patients accurately. So the question for the 8th staging system is that could we predict survival more accurately? So this is why more than 100,000 patients' data were recorded in order to evaluate and create 8th staging system. And this is why some of the T factors have become more detailed. Some of the M factors have become more detailed M factors. Even with these differences, with these changes, even ISLC used more than 100,000 patients. Today, the prediction factor is about only 80%. It is lower than that of breast cancer or colon cancer or melanoma. It is lower than most of the cancers. This is why other histopathological factors may be used for TNM factor, but TNM is strictly anatomical definition. This is why today we don't tend to use histopathological or host factors or environmental factors. But there are some tumors in which other factors are used for TNM staging, such as breast tumor. So this is why it became a little bit more complicated. But if you look at the staging table carefully, and if you focus this table, it becomes actually clearer and clearer, but it takes time.
Sure. Now, the next clinical scenario is a tumor with a nodule in the same lobe,
yes,
and a nodule in the other lobe on the same side, ipsilateral.
yes.
So
yes.
that changed as well. So tell us about that. A tumor, primary tumor with a nodule yes. in the same lobe, and a primary tumor with a nodule in another lobe on the same side. What is the implication?
Okay, so if there is a tumor in the tumor in the same lobe, the other nodule in the same lobe, it should be staged as T3. But if it is in the other lobe, it should be staged as T4. But there is a difficulty for defining this, because a nodule, for example, you have a patient with one tumor, 3 centimeters, say, and 1 centimeter. If the nodule is, the pathology of the nodule is different from each other, I mean, if you have a right upper lobe tumor, adenocarcinoma, and if you have a right lower lobe tumor, for example, squamous cell carcinoma, we should use the highest T factor, which is T2 or T3. But if pathology, if it is proven that one nodule is a metastasis of the adrenal, which it is almost impossible in terms of molecular biology and the pathology. If one tumor is supposed to be metastasis of another, it should be staged as T4. If there are same, the nodule pathology is the same as the main tumor. And we have actually, we had a patient with 3 tumors at the same lobe, and 3 tumors were had different site histopathologies, and we call them T1 tumor, because every tumor was T1 tumor, T1A, T1B, and T1B tumor. So if your pathologists say that these tumors are definitely different from each other, we should use T factor for each tumor. But if there is a suspicion of being a metastasis from one another, the tumor should be staged as T3 if the nodule is in the same lobe, and or T4 if the nodule is in the other lobe. If the tumor is at the contralateral lung, it should be staged as M1A, because it is an extra hemithoracic metastasis on the contralateral side.
Thank you for that clarification. So it's very clear that tumor in the same, a second nodule in the same lobe is T3, a second nodule on the same side but another lobe is T4, and a second nodule on the other side is M1A. Thanks for that. Now, another question I'm going to ask you. Now, I'm asking you these questions on behalf of the students. So the next question I want to ask you is, you said that pericardial effusion is M1, according to the new guideline. Yeah. So what is pleural effusion? How do you categorize pleural effusion?
Again, M1A. Pleural effusion is M1A.
Okay. So pleural is also M1A and pericardial is also M1A. Okay. Now, next question is coming from the audience. They just want to know, you spoke about PL1, PL2, PL3. And you said that PL2 and PL3 are T3 disease. Just quickly go through, what is PL0 and PL1? Is it T2 or is it T3? I mean, there's a bit of confusion there.
Yes, if there is a PL3, it is definitely PLT3 or PL2. It is definitely T3. So if it is if the tumor invades visceral pleura with or parietal pleura, it should be staged as T3. But if it doesn't invade visceral pleura as PL1, if it doesn't invade the elastic lamina, it should be PL1 or PL1. And again, the definition should be T2A or T2B, depending on the size of the tumor.
So what if you've got a 6 centimeter tumor with PL1? What do you stage that?
If it is 6 centimeter, it should be named as T3 because 6 centimeter is larger than 5 centimeter.
5 centimeter. So the primary size is more important than the PL differentiation. Yes. So what you're saying is if it was a 4 centimeter tumor and it invaded the parietal and the visceral pleura, then it becomes T3, correct?
Yes, correct.
So ideal definition for T3 is 5 to 7 centimeters. But yes, even if the tumor is less than 5 centimeters, but it is invading the parietal or the visceral pleura, which is PL3, then it becomes a T3 rather than a T2. Is that correct? It's just for the audience. I'm clarifying.
Yes. Okay, and sometimes even 1 centimeter tumor can invade PL3, can invade parietal pleura.
I see, and that becomes PL3. A T3, and it becomes a T3 rather than a T1. Okay,
T1.
Fantastic. Yes. That's excellent explanation. I really love that part. Okay, another question has come from Dr. Yaldo. She's asking if there is pleural and pericardial effusion, and the first cytology comes negative. How many times should you resend cytology before excluding it from being M1?
Actually, it depends on your pathologist or cytopathologist. Actually, they say if you have a experienced cytopathologist at your institution, 2 times is enough. Actually, 10 years ago, they said that because there were 2 papers citing this, that they said please take as much pleural effusion as possible. Usually we used to drain whole pleural fluid, and we used to send 1,000 milliliter of pleural fluid or 1,500 milliliter of pleural fluid in order to increase the accuracy. But today, cytopathologists usually don't require a large volume of fluid. And if you send 2 times the 50 milliliter of tumor is pleural effusion, it is enough to say that it is not M1A. And sometimes if you have a suspicion that you didn't take your pleural fluid from the main site, I mean, sometimes the pleural effusion becomes loculated, and in a patient, sometimes there are some small loculations that are not representative of the pleural effusion, and it is possible to use videothoracoscopic sampling, or sometimes ultrasonography is helpful to take a large amount of our main space that contains the pleural effusion. So it is you should be very careful about the location that you take the pleural fluid from.
Okay, so basically the message you're giving out to the audience is that radiological appearance of pleural fluid does not mean it is M1. It is cytopathological confirmation that is needed before you can call it M1.
Yes.
You
Yes,
can get
definitely.
a sympathetic effusion in the presence of cancer, which may not be a malignant effusion. Is that correct?
Yeah. Yes, this is called paramalignant effusion, not malignant effusion.
Okay, so paramalignant and malignant. So there are two different
Malignant
types.
effusion.
So
Yes.
one which you prove cytopathologically that this is malignant is a malignant, and one that is
Yes.
not proven cytopathology is not a malignant effusion. So this
Not a
patient should be
malignant.
treated as the primary size of the tumor. So if it is a T2, you should call it T2 and then operate on the patient.
Yes.
Okay. Another question is, can you operate on anybody with 3B?
3B, no. If there is
there any role for
stage 4
surgery in 3B at all?
I don't think so, actually. If you have a carinal tumor, T4 tumor with lymph node positivity, if a multidisciplinary team concludes neoadjuvant therapy plus surgery, it can be done. It depends on the neoadjuvant, your multidisciplinary team. But usually, as I showed you the curves, survival curves, these patients should be referred to oncological therapy, because recently Pacific trial showed that these patients can have a approximately 45% of 5-year survival with definitive chemoradiotherapy plus immunotherapy. So I don't think that there is a role for surgery in 3B patients.
Okay. What about
stage 4 patients? It's different. If there is a solitary metastasis, and if there is no mediastinal lymph node positivity, and if the solitary metastasis is resectable, after this solitary metastasectomy, such as adrenalectomy or cranial metastasectomy, one can perform tumor resection, lung tumor resection.
Okay. What is the role of TNM staging for in situ carcinomas? T in situ carcinomas.
Yeah, actually, I didn't talk about that. In situ carcinomas should be staged as TIS, in situ carcinoma. And there is a very strong discussion going on this subject, actually. So I am a member of, as you said, nicely, thank you very much for the very nice introduction. I am the member of 9th staging committee, and some of the surgeons and pathologists argued about naming in situ carcinoma as non-malignant tumor, because when we look at the literature from Asian countries, from Japan especially, the 5-year survival is about 100% for the patients with in situ carcinoma, and also it is true for the patients with purely lipidic adenocarcinoma, which is minimally invasive adenocarcinoma, which is staged as TMI, minimally invasive carcinoma. So these carcinomas are small carcinomas, smaller than 1 centimeter, and there should be no invasion around tissue. It is one step ahead of in situ carcinoma, but the survival is almost same, about 100%. This is important because these are the probably patients who are candidate of sublobar resections, segmentectomies. So usually, lobectomy is the preferred resection type, but these patients can have segmentectomy because of the high survival rate.
Okay. The next question is about invasion of the diaphragm.
Yes.
You mentioned about T2 and T4 Just explain that again, please. What is the invasion of diaphragm, and is it partial invasion or complete invasion across into the abdomen? What is the difference?
Yeah. Firstly, I have to say that a tumor usually doesn't involve diaphragm. So in my professional life, there were many tumors actually that were said to invade diaphragm. But after resection of the diaphragm and the tumor, many of those turned out to be not invading diaphragm. So invading diaphragm used to be staged as T3 according to 7th staging system. But when the committee analyzed these tumors, I think very small number of tumors were analyzed. The survival rate was very low. So this is why they changed the T factor from T3 to T4. When I answer your question, what is the involvement of diaphragm? The diaphragm is deemed to be involved if the tumor involves muscle fibers. If the pathologist describes the muscle fiber involvement, which is very rare, as I told you, it should be staged as T4. But if, as you know, there is a layer, parietal pleural layer, just onto the diaphragm. So if the tumor invades only the parietal pleura, which is the case in most of the patients, it should be staged as stage T3. T3, so not T4. But okay. The diaphragmatic muscle invasion should be T4. Actually, fundamentally, if the tumor invades diaphragmatic muscle, it practically invades actually subdiaphragmatic area, which is actually fundamentally intra-abdominal area, just above the peritoneum. So this is why probably these patients' survival were found to be very low. So it should be the pathology reports should be examined very carefully in order to show fiber invasion. So pathologists should define fiber invasion, muscle fiber invasion.
So just to repeat for the audience, if the pleura over the diaphragm is involved, it is T3. And yes. If the muscle of the diaphragm is involved, it's T4, correct?
Yes, yeah, correct.
Okay, so now next question is a nice question. They are asking about oligometastasis. So they're talking about a tumor in right upper lobe with an N1 node and a solitary brain metastasis in the PET. What is the, what is the next step in this management?
Solitary brain metastasis with the tumor.
Yeah, solitary brain, a tumor in the right lung, upper lobe, say, with an N1 disease, and a solitary brain metastasis on PET. Or MRI, actually, that's what they meant. Solitary brain metastasis on MRI.
MRI. Okay, so usually MRI is very sensitive for solitary brain metastasis in in cranium or adrenal. So the first step is to understand if there is only one solitary metastasis in the brain or adrenal. If there is only one, or sometimes even the fact that the patient has 2 or 3 metastases, these metastases sometimes can be treated by neurosurgeons, resections, or sometimes SBRT, because SBRT is very effective against solitary brain metastases, and sometimes 3 or 4 metastases. I had a patient with 4 cranial metastases, and these metastases were ablated with the use of SBRT. If these metastases can be cured, can be resected or ablated by SBRT, mediastinoscopy should be performed first. If you have EBUS TBNA at your institution, EBUS TBNA should come first, and mediastinoscopy is preferred, should be performed, because we have to be sure that the patient has no mediastinal lymph node positivity. And after being sure that the patient has no N2 or N3 disease, the tumor can be resected, the metastatic tumor can be resected or ablated, and then it is possible to resect the pulmonary tumor. Sometimes, if the surgeons are available, the adrenal tumor and pulmonary tumor can be resected at the same time, same session. But N0 status is very important in these patients. Otherwise, it doesn't make any sense to perform a resection. It could be seen as paradoxic, because we are okay with performing M1A, M1B patient, but we are seeking for N0. But many studies showed that if you perform surgery for the metastasis and the pulmonary tumor in a patient with N2 or N3 disease, the survival rate, 5-year survival rate, is about 10 to 15%, which doesn't make any sense actually. But if you have a patient with N0 disease with solitary metastasis, it works actually.
So the same patient, what is the survival of a patient with a single nodule, N0, and 1 oligometastases in the brain, both operated? What is the 5-year survival for this group?
It depends on the, of course, the pathology and the tumor, but it is reasonable to expect about 35–40% of 5-year survival in these patients, between 20 to 40% of survival in 5 years.
Okay, fantastic. So it's worth doing these surgeries. Next question.
If the patient underwent a cranial surgery or SBRT, usually it is recommended to perform whole cranial irradiation just after the resection. And usually, as far as I see the patient with cranial metastasis, I send the patient to radiotherapy. And during the radiotherapy, I prefer to perform mediastinoscopy. And if the mediastinoscopy is negative, I say usually to the radiation oncologist that please perform whole cranial radiation, and then I prefer to perform resectional surgery.
Okay, fantastic. So the next question is, you discussed N-staging, and you told us all about N-staging. You mentioned right at the start NX. What clinical situation is there when you will have an NX?
Okay, thank you for this question, because it needs an explanation. So NX is like a head in the sand. It's like an ostrich syndrome. So sometimes if we don't like mediastinal staging before the operation, and if there is no lymph node sampling before the surgery, or if the patient underwent resectional surgery, for example, if the patient undergoes lobectomy without any lymph node dissection, it should be staged. These patients should be staged at NX. Sometimes we can have some PET-CT reports without any mention of lymph nodes, mediastinal or hilar lymph nodes. It happens sometimes, because if the the PET CT is performed in a center in which there is no thoracic surgery or lung cancer management, the report sometimes doesn't contain any information about lymph node positivity. So NX stands for a situation in which there is no evaluation, radiological and or surgical evaluation of lymph node in a patient. If the patient undergoes suboptimal lymph node dissection, such as one lymph node sampling during the operation, it is okay to call it NX, because we should dissect at least 3 lymph nodes, 3 lymph node stations, ideally 6 lymph nodes from 3 lymph node stations during a resection or after the resection of a lung tumor.
Yeah, so this point is very important. Thanks, Akif, for that, because there are some people out there who do a lobectomy and don't bother with lymph node dissection.
Yeah.
So the NX comes into that scenario where, you know, you have done a lobectomy and you have done no lymph node dissection. I have done a lobectomy and I've done lymph node dissection. If my N0 comes back as N0 in pathology, it's truly N0. But that surgeon's histopathology will also come back as N0 because there are no lymph nodes dissected. But that is not N0, it is NX. So that is the situation. Yeah. So excellent, very, very well explained. Now, next question, Akif, is we know metastasis is metastasis. It's got a bad outcome. Why have we confused it for everybody and made it into M1 A, B, C? What is the difference, for all these various further substaging of metastasis, the M part of the TNM?
Yeah, it's again because of survival. So everything should be based on survival. We knew that before this 8 staging system, the patient's survival rates were very variable. Some of the patients had 40% of survival, as I told you before, and they can be benefited from metastasectomy plus pulmonary tumor resection, and some of them had 5 or 3% of survival in 5 years. So this is why there had to be a subclassification of M1 status. So this is why now we have M1A, M1B, and M1C. Actually, from my perspective, M1B and 1C should be divided into 2 subgroups, because today as surgeons we performed operation for tumor and plus 1 or 2 metastases. So 2 metastases is called multiple metastases, but I think 2 metastases could be different from 3 metastases and or more than 3 metastases, because when we come across a patient with 2 cranial metastases, multidisciplinary team can say, okay, it's okay to resect these metastases. And this is why I think it's again suboptimal subclassification. But of course, it is a little bit, it seems a little bit confused or complicated as it is. But the short answer is survival. So every time these subclassifications have been based on survival classification, survival differences. If there is no survival difference, it shouldn't be different. It shouldn't be in the different stage.
Okay, fantastic. So that's very, very well explained, Akif. One question was, you beautifully mentioned about the positron emission and the difference it makes when you are talking about N1 and N2 with the halo around the tumor. or halo around the lymph node. The audience wants you to please just explain that once again, the concept of annihilation that you mentioned during the PET scan.
Okay, actually, I skipped one slide. If you allow me to show one another slide.
Yeah, you'll have to share your desktop
to explain.
for us.
Okay, first I want to should find the slide again. Sorry. Okay.
While you're looking for it, I just want to tell the audience that
Okay.
don't send your question on chat, because I can't keep looking at 10 places. Send it on Q&A. Rajesh Singh has sent a lot of questions on chat, and I just realized that they are pending. So send your questions on Q&A, and I'm quite happy to ask. Yeah, go ahead, Akif.
Okay, so we have to talk about the structure of the atom. So remember the high school classes, they taught us that there is a nucleus and there are electrons around the nucleus. It is true, but there is one difference. Actually, when the atom is so empty that if the nucleus is like an orange, the electrons is in this analogy is like spectators around the football field. So the length of the football field is about 100 meters. So this is why we call the atoms are defined as 99.99999999% empty. So someone made the calculation that if we extract whole spaces in 7 billion people in the world, we can be squeezed in one sugar cube. So this is how we are so empty. So what is the implication of this? When we use positron emitting fluor atom containing a glucose molecule, positron goes out from the nucleus, but positron cannot meet an electron for trillions of atoms. So usually, as a statistical calculation, usually positron travels approximately 6 to 8 millimeters to find an electron, and then to be annihilated, and then to emit a gamma ray, which is detected. This is why every lesion, when we look at lesion, we don't look at the positron emission. We look at the gamma ray emission, which is approximately 8 millimeter distance from the tumor or lymph node. So this is why there is a halo just around the lymph node or the tumor. This is a subatomic phenomenon. So it has nothing to do with the calculations. It has nothing to do with the detector sensitivity or other things. And from 1,000 years from this, from today, we will be maybe talking about, or grandchildren and grandchildren will be talking about this phenomenon. So this is why when we look at N1 node and the emission from N1 node, this emission could be from mediastinal lymph node, because this distance sometimes is shorter than 8 millimeter or 6 millimeter. This is why when we see N1 lymph node positivity on PET CT, we have to perform mediastinal staging modality, EBAS, EUAS, or mediastinoscopy. So this is why we see always halo around lymph node or tumors all the time. So if, of course, there is a tumor, there is a peripheral tumor without lymph node positivity, of course, there shouldn't be any convergence between the tumor and the lymph node. But here around higher structures or M1 node or N2 nodes, we should be very careful when we interpret this PET-CT positivity.
Okay. Fantastic. That's very clear, actually, that concept. Okay, stop sharing and come back onto the main screen, Professor Turna. And we've got a few more questions. Are you okay for time?
Yes, sure.
Okay. So Dr. Rajesh Singh, who's a surgical oncologist, he's asking this question. It's a nice question. I like it. Says, when we do mediastinoscopy, the specimen comes out in multiple small pieces, and there's a risk of microscopic spillage, similar to R1 resection concept. Does this cause upstaging of tumor? And if this is correct, this factor should be considered in staging.
Yeah. During VAMLA, video-assisted mediastinoscopic lymphadenectomy, we resect lymph nodes completely if it is possible. But yes, we usually take the biopsy piece by piece if it is not possible. We didn't see any one spillage or recurrence around mediastinum. Even the fact that we performed more than 1,200 VAMLAs. So we didn't see any one of them. Probably there is a inherent resistance to this spillage or tumor recurrence around mediastinum. So on the contrary, we have seen higher survival rate who had VAMLA before the surgery. So this is why I routinely prefer to perform VAMLA before the resectional surgery. We didn't see any.
So taking a mediastinal lymph node piece by piece, there is no evidence to suggest that there is soiling of the tumor. Okay, thank you.
Or there is no evidence to say that it is upgraded.
Upgraded, okay. Another nice question. Two situations. Central tumor arising from parenchyma, invading directly the carina. That's one. Versus primary tumor arising from carina. Are they both staged differently?
Actually, by definition, they are staged T4. But maybe there is some survival difference between two tumors. But if the tumor invades carina, it should be staged as T4. Actually, if you want to find the logic behind it, when the tumor goes into carinal area, mediastinum, there is a high possibility that this tumor can metastasize through the lymphatic network, or it's a higher possibility that the tumor can metastasize in the distant organs. So maybe there should be a difference. One of my friends actually has been looking for the definition of the size of the tumor. He has been looking for the larger tumors, 9 centimeter, 10 centimeter, and he is comparing these tumors with the relatively smaller carinal tumors. And he said that there is a small survival difference between the larger tumors and the relatively smaller carinal tumors. We will see maybe in 9th edition, we will see.
So at the moment, they are all T4. Okay. Thank you. Now, next question is when you're working on the 9th edition and you're making draft for the TNM, do you take into consideration racial or subcontinent survivals or different races? Is there an impact on survival? because Asians are known to have EGFR mutations, which favors good prognosis compared to the West.
Yeah, we'll see. Actually, there is one confounding factor. For the age-staging system, among approximately more than 100,000 patients, 80% of the patients who had complete lymph node dissection came from Asian countries. So actually, practically, when we talk about the impact of N status, we are talking about Asian. So when they look at the before the age staging system, age staging papers were published, they looked at the survival difference, and they found that Asian the patients from Asia survive longer. So probably this is one of the reasons that they survive longer, because they had more complete lymph node dissection. About the EGFR and the genetic mutations, yes, in the database of 9-staging system, almost all genetic factors that are analyzed can be entered, including next generation sequencing. So if you have you are the institution who can do next generation sequencing, you can enter more than 10,000 genetic information into one patient. So if there will be enough patient number who had these large big data, then there will be possible to look at these small or large or haplotypal differences in these patients. But there should be many more tumors in order to analyze small differences.
Okay, last two questions, if that's okay. Very short questions. Sure. The second last question is, how common is sympathetic effusion without being M1?
I don't know the number, but we have a database that includes more than 700 patients with pleural effusions. We have been trying actually to create a paper on that. Approximately, I think I would say 1/3 of the pleural effusions in the patients with known malignancy. I mean, not only the lung tumor, but with other tumors, are non-malignant pleural effusions that can be called paramalignant effusion. 1/3 actually. So it is not recommended to stage the patient M1B when you see pleural effusion in a patient with tumor.
Thank you.
It happens more commonly in the patient with the ovary tumor, especially, and also, of course, with lung tumor.
Of course, yeah. Okay, last question. Because you are in such a privileged position, you are part of the committee that's writing the 9th guidelines. We want you to give us a sneak preview, of course, highly confidential, but two questions. One is, when is the 9th edition likely to come out? And what are the major changes that we can look forward to in the 9th edition?
Okay, it's a 1 million.
But you don't have to tell me. You don't have to tell me. So, it's okay. I just, on behalf of the audience, I'm asking you this question.
Okay, so the database committee actually will end the data entry in 2023, and about in 2025 and 2026 there will be new papers, and expectedly the 9th staging will be in effect in 2027. There are many changes actually talking in these meetings. There are, of course, some confused areas. One confused area is to define the tumor, part solid tumor definitions. Which metrics should we use? Should we use, should we measure the GGO areas with solid component? Should we measure only the solid component? Sometimes the solid component is not circular, it is very irregular. There is some definition. There are some discussions about this. The other discussion in pathological evaluation is about STAS, so spread through airway spaces. So these are very interesting tumors. Two prominent pathologists say that it is a fact, and the one other pathologist in the committee said that it is an artifact. There is no such thing as STAS. But we know that from some papers, STAS is very important pathological factor. About more definable T factors, I think mediastinal invasion should return as a factor, as an important factor. And personally, I insisted to look at the simple cytopathological factors such as perineural invasion, lymphovascular invasion, and vascular invasion. I think these invasions, especially the lymphovascular invasion, is important in terms of survival. The other the thing that have been discussed is that should we create a subclassifications according to number of lymph node positivity, like in the case in esophageal tumors. So if we have 2 station positive N2 disease, is it these patients are have worse survival? Of course, there are some papers, and 8th staging committees suggest that the N2 disease is worse than the single station N2 disease, and skip metastasis is better than non-skip metastasis. But the first of all, is it possible to validate these findings? And of course, we should use these findings preoperatively. I mean, we have to show this on the radiological examinations in order to use it consistently. This is one of the discussions that have been going on. And lastly, but very importantly, genetic factors can be used, maybe not probably with a component of TNM staging, but maybe they will be used as some accessory staging parameters. Since it is almost not possible to use them before the operation, it is very small probability that we will use these factors. But there is a thing called liquid biopsy. So some of the studies show that blood analysis can show some of the genetic factors that are coming from the tumor. So maybe it will be possible to use some of the genetic factors such as KRAS, EGFR, P53, BCL2 as an adjunct to TNM staging system. So Dr. Asamura once said, no change, but I don't agree with him. Yeah. So he explained his idea, his opinion, but I don't agree with that because, as I said before, this staging is complicated, but it is still suboptimal.
So I think to conclude your conversation, you did say that the 7th staging was around 70% accurate if you put a patient in, and now it's 80%. So we are trying to actually increase that probability with the 9th staging, and we are trying to include factors like liquid biopsy, factors like straight through airway spaces, and I think you have suggested perineural invasion and perivascular invasion, whether these factors make a difference to survival. Thank you very much, Professor Turna.
Because let me explain one thing. Because we have still aha moments. For example, when we operate a patient with T1A tumor, sometimes some of the patients can come to us with multiple metastases, and we say, aha, how could it happen? And sometimes we were talking about operating a patient with N3 disease, and we happen to say that, no, it's important, the patient is important, not the stage. So this means that the staging system is still suboptimal. So we have to decrease the aha moments, and we have to make it as perfect as possible.
Fantastic. Professor Turna, this has been an absolute honor and privilege. I have to say, I am so privileged to sit and moderate this session with you. It's been a great learning experience for all of us on this forum, and we are extremely grateful to you for having given us the time and also given us an insight into your great knowledge about this subject. It is a complex subject. Students frequently struggle with the TNM staging, but I think it has been made absolutely clear by you during your talks, and also the way you handled the question and answers was just immaculate. So once again, thank you very much, and we are very, very grateful for your time. Good night, Professor Turna, and good night to everybody else. I hope you had a great session and you enjoyed it as much as I did. Thank you.
It's been a pleasure. Thank you.
Thank you, sir. Good night. See you.